We're going to be talking about basal cell carcinoma in this video. Basal cell carcinoma, or BCC as we often abbreviate it in Dermpath, is a very common form of skin cancer. It usually occurs in lighter skinned patients who have been exposed to ultraviolet radiation, either from sunlight or tanning beds, things like that. And it can occur in other settings as well. Most basal cell carcinomas, if detected early and treated, have a very good prognosis and are easily taken care of, but some can get quite large, and especially if they're neglected, they can grow deeply into nerves and other structures, and when they're on the face, they can cause quite a bit of damage. So these are very common tumors. They're usually not a big problem for patients, but I've seen some cases that were. So they're important to understand and to know about. This is a real basic bread and butter dermatopathology because we see these tumors multiple times each day. So usually in Dermpath we start at low power, but here I'm going to start at higher power to show you what the classic features of basal cell carcinoma are. What you see here are these nests of blue-looking cells. So these small blue-looking cells that have large nuclei but very little cytoplasm, that's why they look blue. We call those basaloid cells. So when something is basaloid, it means it's kind of nests of bluish-looking cells in the skin. So we use that term a lot in dermatopathology. And here what you can see is there's this very unique kind of bluish areas around the outside of the tumor nests. Let's go a little closer. And that blue material right there, that's, we call that in Dermpath mucin. In other parts of pathology, people often refer to that as myxoid change. Whatever you want to call it, it's basically ground substances like hyaluronic acid. And these are being probably made by the fibroblasts around the tumor. And they make this kind of pool around the edge of the tumor. And you don't always see this, but you often do. And what happens is during processing of the tissue in the laboratory, the tumor separates and makes kind of a cleft between the tumor and the surrounding pink collagen of the stroma. And that clefting artifact, although it's an artifact that happens in the lab, it happens so commonly in basal cell carcinoma that it's a really useful diagnostic clue for us that something's a basal cell carcinoma versus other mimickers. So that bluish mucin there is really helpful and good to see, as is the clefting artifact. And also what you can appreciate here, let's go to these nests, you can see it really well here, is that around the outside of the nest, the blue cells, they kind of get long and tall rather than kind of small and round like they are in the center of the nest. And around the edge, they kind of all line up in this parallel row. So people have kind of likened this to a picket fence. So the term that we use to describe this is called palisading, basal cell palisading. The palisading of bluish cells that are taller around the periphery of the tumor is another really useful clue. It's a classic feature of basal cell carcinomas. So seeing that palisading, that mucin, the clefting artifact that divides the tumor nests from the pink stroma, the pink collagen of the dermis, all of those are very useful features for basal cell carcinoma. Now, when we diagnose basal cell carcinoma, we usually like to figure out what growth pattern the tumor has. And the reason is that there's some differences in behavior between these growth patterns and differences in the way you can treat the tumor. So this example here, down at the edge of the tumor, you can see that the tumor basically has these kind of nodules. And so overall, the shape is kind of one large nodule. It's made of kind of multiple smaller nodules, but they're all kind of growing together in a clump. So we call that the nodular pattern of basal cell carcinoma. It's one of the more common patterns we see. It's kind of what I think of as the run-of-the-mill normal basal cell carcinoma, if you will. It's the usual pattern. And then from there, we can kind of learn the other patterns. So let's come over to this piece at this edge. You can see similar features to what I just showed you. If we get a higher power, you see that these basaloid nests have blue cells around the periphery, right here. And those cells are lining up into that kind of palisade or columns. They're kind of long, tall cells that kind of are stacking up alongside each other and making palisades. So that's really useful. The mucin is a little bit more subtle here. There we go, that's better. The mucin is a little more subtle here. It's kind of a pale bluish color. And sometimes on older slides, this slide's a little bit older, the bluish mucin kind of fades and washes out, and that's why it's a little harder to see. But even when the mucin is not present, look at one thing here before we talk about this subtype. Here's the kind of more normal dermis. There's pink collagen, but up here, look what happens. The collagen gets kind of loose is some little scattered blue lymphocytes here, these inflammatory cells. There's some dilated blood vessels. This kind of area right here looks a little different than the dermis does down here. And this is what we call basal cell stroma. It's this kind of unusual reaction that the body's, that the dermis has against the basal cell carcinoma growing there. Other types of tumors, when they invade, often do produce kind of a reactive change like this, but the reactive change in the dermis around basal cell carcinoma is very distinct appearing. After you get used to seeing it, you'll recognize it, and sometimes on the initial look at the biopsy, you might not see any cancer there, but if you see some of that stroma and you cut some deeper sections into your block, lo and behold, you'll find a basal cell carcinoma. So I think it's really useful for student dermatopathologists to learn to recognize this stroma and the mucin around a basal cell, because I've had many times where there was no basal cell on my initial section, but the dermatologist wanted a basal cell clinically, so I cut deepers and it was a little shaved biopsy, and then there was a basal cell on the deeper level. So it's a really useful clue to basal cell hiding out nearby. And basal cell can sometimes be very subtle when it grows along the surface, or right along the bottom, excuse me, of the epidermis. So here you can see a little nest of basal cell that's kind of budding down from the dermis, or from the epidermis, and pushing into the dermis a little bit, but it's not detaching and growing as distinct nodules. So we call this the superficial pattern of basal cell carcinoma. And this one also I would call superficial pattern. So when you just have this pattern, that's important for the dermatologist to know, because when there's only superficial basal cell carcinoma present, sometimes they choose to treat with topical agents like imiquimod, which is an immune modulator that causes the immune system to fight off the cancer and make it go away. And this can be a really useful tool if the basal cell is near the eye or a very sensitive site where surgery wouldn't be as ideal. So for superficial pattern basal cell carcinoma, that's an important thing for the dermatologist to know in some situations, because of treatment. And also superficial basals, they look different. They're a little bit more like a reddish plaque or patch. They can sometimes even resemble forms of dermatitis clinically. So they can be tricky to diagnose sometimes. Clinically, they look a little bit different, and they can be treated a bit differently. So that's why we point out when we see that pattern. So that's superficial basal cell, really good example of that. And sometimes it can be so subtle that you almost don't see it. And again, that stroma is a really useful clue. And it can also mimic actinic keratosis sometimes. And again, I look for clefts, mucin, the palisading, and the stromal change. Those are all features that help me if I'm debating between actinic keratosis or a little subtle superficial basal cell carcinoma. Now, let's look over to the other side of the biopsy. Sometimes basal cells have multiple patterns in the same biopsy. So here's superficial pattern. And this is pushing down quite a bit more from the epidermis. The epidermis is kind of missing here. It's ulcerated away and broken loose during processing too. But here again, you can see these nice nodules that have kind of smooth borders around the edge. They have beautiful peripheral palisading like this. Very nice. And mucin and clefting artifact. All the things we want to see. Now, if you look in here a little bit in the middle of the nest, you can see that some of the cells are starting to get a little bit larger and more pink. They look a little bit more like squamous cells. So I see this very often in basal cell carcinomas, particularly basal cells that have been picked at or irritated or have ulcerated. And so this is kind of squamous differentiation or keratinization. Some people get really worked up about this and mention it and call things basosquamous carcinoma. I think that that's probably not necessary. I think most of the time a little bit of squamoid differentiation in a basal cell doesn't mean much of anything. Clinically, it's not going to indicate that the tumor will be more aggressive, in my opinion. If you just see a little bit, when it's really extensive or there's areas that look just like squamous cell carcinoma, then that's a time where you might consider using basosquamous carcinoma or considering a collision between a basal cell carcinoma and a squamous cell carcinoma. I'll address that more in a different video, but for now, I think I just wanted to point out that you can have a little bit of focal keratinization. Here's another area. See, there's one little nodule that looks kind of like almost like a keratin pearl or something like that. Looks like something you'd see in a squamous cell carcinoma, and the cells around it are a little bit more pleomorphic and atypical. So sometimes basal cell carcinoma is very bland, like over here we have much more bland, kind of uniform, monotonous nuclei. And then over here we have more atypical nuclei, a little bit more mitotic activity, and even some atypical mitoses. When I first started Dermpath, I didn't think that you usually had pleomorphism or mitotic activity in basal cell carcinoma, but with experience, I've definitely seen cases that sometimes have even wild pleomorphism, really huge, ugly looking cells, lots of mitoses, mitoses, atypical mitoses, all those things, you can see them in a common basal cell carcinoma. We often don't notice that because you can diagnose basal cell carcinoma from low power usually, so sometimes we don't appreciate the higher power kind of nuances of the tumor. So here again, look at that stroma. You're getting bluish myxoid change, kind of reactive looking fibroblasts, and disorganized kind of collagen deposition. All of that is a good clue to the basal cell carcinoma stroma. Here there's actually a few giant cells, and there's a little hair shaft there, so probably there's a ruptured hair follicle associated with this tumor as well. That happens sometimes. So again, beautiful. Look even from low power here, you can see that nice clefting artifact, that space around the outside of the basal cell carcinoma nest, a useful clue. And even from low power, usually, you can make that out. You can see the blue basaloid appearance, the palisading around the periphery, the bluish mucin, the clefting artifact. So you can oftentimes figure out that you're going to see a basal cell carcinoma even when you're at low power. All right, let's switch to a different case. We'll start over here first. Look, low power, you've got blue basaloid nest. You've got clefting artifact, beautiful clefting, that white space there. The mucin is kind of washed out during processing, and what you're left with is a white space. So here we are on the 2x objective, the lowest power I have on my microscope, and already I can tell that this is going to be a basal cell carcinoma, no problem. Here it's making kind of a nodule that's detached from the epidermis, so I'd call that nodular pattern. All these, see these over here? Don't miss those. They can be very subtle. That's superficial basal cell carcinoma. And look at each of these blue little buds of basaloid cells coming down from the epidermis. Each of those represents a little island, or excuse me, a little bud of tumor. So there, basal cell carcinoma there, there. It's skipping along the epidermis. And so that's, again, the superficial pattern. Look at that cleft. Even in these very, very tiny ones, that clefting artifact is often there. You can kind of appreciate how the cells are lining up and palisading here. So that's a real useful clue if you're struggling to detect basal cell carcinoma. It can be subtle, and it's easy to overlook. Again, that stroma. Out here is kind of more or less normal dermis. For this patient, it's got some sun damage, of course. But as we get over here, the dermis gets more disorganized, and kind of loose collagen gets inflamed, and that's that kind of a tumor stroma that we see around basal cell. So superficial basal cell here, a little nodular basal cell there. Look, more little nests that are clinging to the base of the epidermis. They have that clefting artifact. They have the stroma, so this is more superficial basal cell carcinoma here. Now, let's look over here, and the tumor looks quite different. The nests are still blue and basaloid. And we'll get to focus here. You can still see areas like this with peripheral palisading, those kind of tall columnar cells that are lining up parallel to each other around the edge of the tumor nests, kind of pointing inward. But what you can appreciate is that the nests no longer are kind of round and smooth, but here they're very jagged and pointy at the edges and angulated. And then over here you can see that these big nests are transitioning out into areas where you have little thin fingers of tumor that are kind of infiltrating the dermis around. And when you look at the deeper aspect of the tumor, those little fingers and irregularly shaped nests of tumor are actually infiltrating all the way down into the subcutis, into the fat. And the immune system is very unhappy about this because look at all the lymphocytes that are kind of responding to the tumor here. So these irregular nests are infiltrating cords of tumor. We call that infiltrative pattern basal cell carcinoma. Now there's a lot of different names that get used: morpheoform, sclerosing, micronodular. Those are all different patterns of basal cell. My personal view is to just kind of lump those together under the term infiltrative basal cell carcinoma. The reason I bring this up in my report is to let the dermatologist know this is a basal cell carcinoma that might be more locally aggressive. It has a tendency to kind of infiltrate and invade into the surrounding tissue. So they might need to treat this with complete excision or even with Mohs surgery technique, which is a special form of surgical excision with frozen sections that allows the margins to be evaluated kind of in real time while the patient still has an open surgical defect and is being operated on. So it gives them a rapid look at the margins. So sometimes they will use Mohs or other complete surgical excision modalities to make sure that these tumors are completely removed, because they have a higher chance of growing back if you just use electrodesiccation and curettage, which is kind of scraping and burning. You can use that for some forms of basal, but it's a less effective way of dealing with these infiltrative basals. And see, look, this really does infiltrate, little islands of tumor invading all the way down. And look at that kind of bluish background, kind of pale bluish stroma, that desmoplastic stromal reaction that we see around the tumor, a very useful clue for basal cell carcinoma. Let's go to higher power. Little islands and cords that are kind of jagged and haphazardly arranged that are infiltrating all the way down here into the fat. So, and in infiltrative basals, particularly when they go deeply into the fat, I always look for perineural invasion because you can see that from time to time, and it's good to know because again, it might indicate a higher risk of local recurrence if you see that. Let's switch to another case. So here's another example of basal cell carcinoma. This one's coming from the scalp. You can see that we're in the scalp because you have really large anagen phase hairs that have their roots buried down in the subcutis. So when you have large hairs with roots in the subcutis, usually you're in or near the scalp. All right, and if you look up here in the dermis, you can tell that the pink dermal collagen has actually been mostly replaced by this kind of these squiggly grayish blue fibers, and these are elastic fibers. So when you see this is called solar elastosis, and it's seen in people who have had long-term chronic ultraviolet radiation exposure, either from lots of tanning or being out in the sun a lot, or both. And in this sun-damaged scalp, probably from an older individual, you can see that there are little islands of basaloid cells. So typical basal cell carcinoma. And if we go down here, you can see some of the islands even have that clefting artifact, where that's white space that divides the tumor cells from the surrounding dermis. And so that's another useful clue for basal cell carcinoma. But look here what we have. You can see now that there are these little tiny strands, little infiltrating islands and strands of blue cells. Those are all basal cell carcinoma. So this is infiltrative pattern basal cell carcinoma. That's very subtle. And you can tell that from lower power, those little islands, those little tiny fingers of infiltrating tumor can be very sneaky, especially when the background has a lot of that funny reactive desmoplastic stroma that you see often in basal cell. So when I see that, sometimes I'll even make a comment in my report that there are many little very subtle islands of tumor cell that are infiltrating, so that if a Mohs surgeon or another pathologist looks at margins on frozen, they'll be aware that they can be very subtle. And if you want to highlight those and find them and it needs some help, in this case I think you can see it on H&E, but if you need help, you can do a pan-cytokeratin or a high molecular weight cytokeratin like CK56 or P63 or P40, which are nuclear markers that stain basal and squam and some other tumors. But all of those, even though they're not specific markers, they're very sensitive, and they'll help you pick up very subtle infiltrative strands of tumor in infiltrative basal cell. So let's go back over to this section, and you can see that the tumor starting up here in the superficial dermis and is just kind of blasting its way through the entire dermis all the way down into the deep dermis here, getting close to the subcutis. And again, you have to always look very carefully at the nerves when you have an infiltrative basal cell carcinoma. This tumor gets really close to the nerves, but doesn't seem to be, sorry, that's not a nerve, that's part of a follicle. There's nerves right there. And so you got to look closely and be on the lookout for perineural invasion. And again, these are the kind of cords and strands and islands of infiltrating tumor cells with that very unique background, kind of myxoid, loose, disorganized stroma that is typical for basal cell carcinoma. So that this is a very nice example of the infiltrative pattern, or some people would call this morphiiform or sclerosing pattern of basal cell carcinoma. Now let's look at another example. We'll turn it around so it's right side up for the video. So here a biopsy site is a biopsy site, this big divot taken out of the skin. And this slide's a little bit faded, unfortunately. Over time, sometimes H&E slides will fade. Here's tumor, and you can see these little islands of tumor that are trickling way down deep into the dermis. Even from here at low power, you can see them all the way out. Here's tumor, there's tumor down here, tumor down here, down here. It's going almost all the way to the subcutis. And when you see a tumor that's kind of trickling out away from the main tumor mass, you always have to look closely in those areas for perineural invasion, because that's a sign that maybe the tumor's tracking along the nerves. So here, when you see tumor right next to the vascular bundles, that's where the nerves run. So you have to look closely in those areas. I don't see a good nerve right here, but that's the kind of area that you want to look for and be aware of perineural invasion as a possibility in infiltrative basal cell carcinomas. So always look closely at these and examine carefully for that possibility. And again, look at the background stroma. This case, the stroma is a little more dense and pink, but it's very disorganized and reactive. The tumor is invoking that kind of response from the immune system and from the dermis. So a good example, again, of infiltrative pattern basal cell carcinoma. And I think here's one more that we have. And up at the top, you have a very inflamed dermis underneath the reactive epidermis. And down here, look at these tiny little angulated cords and strands of tumor infiltrating all the way through the dermis, all the way down into the subcutis, way down deep. So this is why we call it infiltrative pattern, and again, you could call it morphiiform too if you wanted to, but I think infiltrative pattern gets across the point that these little islands and cords of tumor are infiltrating deeply, and again, these tumors have a higher chance of being locally aggressive and recurring if they're not treated with complete excision. So that's why we worry about this. And even here in these little angulated nests, you can see again that clefting artifact is still there. Palisading is not so obvious usually in these little tiny infiltrating islands and cords, but you can definitely see the clefting artifact some of the time, and that's a useful clue to help you realize you're dealing with basal cell carcinoma. There are some other tumors that can kind of have this pattern, like microcystic adnexal carcinoma, which is a topic we'll have to address in another video in the future, but they can look a little bit like this, but there are some differences that will help you out. So again, infiltrative basal cell carcinoma. So let's look at some other variants of basal cell carcinoma. Let's go back and look at a kind of regular nodular pattern basal cell carcinoma again. So here's another example of a nodular pattern basal. Multiple tumor islands here. They're blue and basaloid at higher power. You can see that they have that beautiful palisading around the periphery. Those tall columnar looking tumor cells that just line up in kind of a single file row around the edge of the tumor nests. So that's very helpful. And then look at all that pale blue mucinous stroma in the background, and that mucin is causing this separation, the clefting artifact of the tumor nests from the pink collagen of the dermis around it. So that's a really useful clue. In this case, really beautifully demonstrates that clefting artifact, the abundant mucin, the peripheral palisading. That's a purple little crunched up area here, that's calcification. So sometimes you can have calcifications in basal cell carcinoma. So this is a nodular basal cell carcinoma. And sometimes basal cell carcinomas can actually exhibit pigment. So here would be an example. So here's a basal cell carcinoma. Again, it's kind of a nodular pattern. You can see it's got the same features as the previous nodular basal cell carcinoma. But when you go in a little closer, you can see that there's some brown pigment in here. And some of the pigment is actually in melanophages in the dermis. Sometimes you can have some passenger pigmented melanocytes that are kind of scattered in the middle of the tumor, and those are just kind of hitching a ride with the tumor. They're not, doesn't mean it's a melanocytic neoplasm. But the important reason to recognize this is that clinically these can make the tumor really look very dark, almost black in color. And for the dermatologist, they can sometimes even mimic melanoma. Now, most astute dermatologists usually will recognize a pigmented basal cell, but I've seen cases that were almost impossible to tell clinically, and only with a biopsy were we able to show that it was a basal cell carcinoma and not a melanoma. So it's important to recognize when the dermatologist is thinking about a pigmented lesion or a melanoma or a nevus, and then the biopsy shows a basal cell, I'll often look for this pigment and make sure to mention it to help explain why the lesion looked the way it did for the dermatologist. And sometimes the pigment can be quite robust. I mean, here, even from low power, you can see there's just tons and tons of pigment. Here's the basal cell carcinoma over here. And then here's all this dense, dense brown pigment. And this is all melanin that's just being deposited there. And don't worry when you see all that, don't be afraid of a melanocytic neoplasm. You can always do immunostains if you're having trouble telling. But here, you can see obvious basal cell carcinoma. And then here you've got abundant melanin pigment. So this is a well-known pattern, pigmented basal cell carcinoma. And this is probably one of the more pigmented ones I've ever seen, actually. It's very, very deeply pigmented. All right, let's look at some other unusual patterns of basal cell carcinoma. So this pattern, you can see that we have basaloid nests. You can see down here that there is peripheral palisading around the nests. But in the middle of these nests, you have these huge open spaces. And if you look closely, these spaces are filled with blue mucin or myxoid material, just like that same kind of mucin that we see in the stroma around basal cells. Sometimes that stuff builds up in the middle of the basal cell islands and makes these round spaces. So we call this the adenoid pattern of basal cell carcinoma because it looks kind of like glands, and it can sometimes be confused with other gland-forming things like sweat gland tumors, adenoid cystic carcinoma, and even sometimes adenocarcinoma. So sometimes you can really have a hard time if you're not familiar with this pattern. So usually I don't even mention this in my reports unless someone has sent me the case as a consult and asked, you know, is this an adenoid cystic carcinoma or is this a sweat gland tumor? And then I'll explain that this is just a funny pattern of basal cell. So I would normally sign this out as basal cell carcinoma nodular type. But I think it's an important pattern, not for the clinicians to know, but for the pathologists to know, because it can confuse us if we're not familiar with it. But it doesn't really have any significance clinically. And you can sometimes get a little bit of pink keratinization or squamatization in the middle of otherwise typical basal cell carcinomas, and I don't get really too worked up about calling that in basosquamous or anything like that. It's very common. I see little islands of basaloid of pink keratinization in basal cell carcinoma all the time, and I think it's just kind of a reactive sort of a shift in keratin production by the tumor. And I think it's important to not get too worried about that unless it's very abundant and you have areas that really look like squamous carcinoma. Then you could consider calling basosquamous carcinoma, but I only very rarely use that term actually. So it's an adenoid basal cell carcinoma here. Now let's talk about basosquamous carcinoma. Let's see, I think I have a few examples here. Here you can see what looks like a regular old basal cell carcinoma, the superficial type. Got these kind of buds and islands that are extending down from the base of the epidermis. Beautiful clefting artifact here. Really nice example. See all of these darker blue cells here? This is all tumor. All of this is superficial basal, and underneath you have that kind of reactive stroma that you often see with basal cell carcinoma. So far no problem, right? Now look over here. You can see that the tumor is transitioning from areas that look just like basal cell into areas that look like clear-cut squamous cell carcinoma, big, huge, ballooned, glassy cells with abundant pink cytoplasm and tiny little keratin pearl formation that you're starting to see here, little dying keratinocytes that have really dense pink cytoplasm. So if I just had this on, on an exam or something, I'd say, oh, this is squamous cell carcinoma. But if I just had this area up here, I would say it's basal cell carcinoma. And here we have the two, not two separate tumors growing together, but actually two parts of a tumor that are closely intermingled together. So in that setting, when I have areas that look like indisputable basal and other areas like indisputable squame, and they're merged together intricately, I'll sometimes use this term basosquamous carcinoma. These can behave more aggressive, and so I think it's important to point that out, but I do feel like that term is overused sometimes, and I think that I really have to see really extensive areas that look just like squamous carcinoma before I'll use that term. I think here's one other example that I think is probably a good solid representation. Here we have really obvious basal cell carcinoma. Sorry, the slide's upside down. And then over here you can start seeing islands that really look a lot like squamous cell carcinoma. I mean, that looks like infiltrating little cords of squamous cell carcinoma. And again, more basal cell carcinoma. And looking at low power, you can see kind of better. There's pink areas here, here, here. And then over here, very obvious pink keratinized areas. And these areas at higher power look just like squamous cell carcinoma. And that looks just like basal cell, and they're closely intermingled together. So I think this is a true example of a tumor with basal cell and squamous cell carcinoma differentiation, kind of divergent differentiation. And so I would use the term basosquamous carcinoma for something like this. But again, it's a term I only use every once in a while and with caution. So do be careful about that. Now, let's see what we have here. Now, the next tumor in our list, this is a really nice example. These long, thin strands that are not infiltrating, like in the infiltrative basal, but they're actually kind of extending down from the epidermis. and they're kind of long strands of little pink cells. And then along the way, you see little basaloid kind of aggregates that are budding off of these pink strands. So this tumor was originally called Fibroepithelioma of Pinkus, and now most people, or many people at least, regard this as a variant of basal cell carcinoma. Some people still draw a distinction between the two, but I call these basal cell carcinoma fibroepithelioma type or fibroepithelioma of Pinkus type, and I think they should be treated as though they're basal cell carcinomas. That's my personal view. But if you study Dermpath long enough, you'll learn that a lot of people have a lot of different views, and Dermpaths sometimes like to discuss those views over the years and argue about them a little bit, all in good scientific fun, of course. So here we go. This is a nice Pinkus type basal cell carcinoma. I believe I have another example here. Oh, that's the best area here. This beautiful example, long, thin strands kind of stretching down and interconnecting to make this kind of network of little thin strands. And then on that little network of pink strands of kind of squamous looking cells, you get little islands of blue basaloid cells. So here's your little interconnected network. Little strands of interconnected pink squamoid looking cells, and then little buds of blue basaloid cells with nice palisading. So some people do say that these may be a type of follicular tumor rather than a true basal cell carcinoma, and I can kind of understand that because they do have a lot of overlap with follicular tumors. But in any case, this is a fibroepithelioma of Pinkus or fibroepithelioma type basal cell carcinoma, whatever name you want to give it. So a very nice example of that. Basal cell carcinomas oftentimes have relatively bland cells, or not a terrible amount of nuclear cytologic atypia, but in some cases of basal cell, you can actually see pretty dramatic pleomorphism. It's not real common, but I think it often startles people, particularly when you start out Dermpath and you expect that basal cells have these kind of uniform blue cells, and then to see an example like this that has, I mean, just a massive amount of pleomorphism. These tumor cells here are dark and really big and funny shapes, and they're like 10 times bigger than their tumor cell neighbors over here. So that variation in size and shape of nuclei from one tumor cell to the other, we call that pleomorphism. And to me, this doesn't signify any increased tendency to behave aggressively. I don't actually even usually mention this in my report. I just call it basal cell carcinoma. And I think it's more important for the pathologist to recognize that you can sometimes have wild atypia. I mean, these are huge, ugly looking pleomorphic tumor cells. And sometimes you can see that in basal cell carcinoma. I feel like usually it's a focal finding, and that you'll find other areas that look more like typical basal cell carcinoma, and that'll kind of help you sort out that it's not a squamous cell carcinoma or something else. So trying to look at areas kind of like this where the pattern looks a lot more like a basal cell carcinoma, and that you can see that you're merging from stuff that looks like basal cell into areas with pleomorphism. That's kind of reassuring if you're worried that you might be missing something else. Now right here, these spaces are kind of artifact that happened from when we were cutting the slides. Sometimes the tissue falls apart for a variety of reasons. But this area looks more like regular basal cell carcinoma, islands of blue basaloid cells, a bit of that mucinous stroma, a little touch of palisading. It's not real great, but it's there. And then what you can see is that this tumor merges directly into a tumor that looks very different, that has large pale cells. And at low power, you can see that those pale zones are really abundant. In fact, this whole piece of the slide over here is just composed of those pale cells. So let's go down and see what those pale cells look like. At higher power, it's sometimes hard to show on video, but let's see if we can do it. These cells have a very, very fluffy, pink, kind of granular looking cytoplasm. So we call this granular cell variant of basal cell carcinoma. There are other tumors like granular cell tumor and some other things that can have very granular cells. And so the reason we need to know about granular cell variant of basal cell carcinoma is just so we don't confuse it with those other tumors that are different kinds of tumors and behave differently. So I think the most helpful thing is seeing the granular cells transition into areas that look just like regular basal cell carcinoma. I think that's the real key to that diagnosis. And basal cell carcinoma also can sometimes have, here's the more typical looking regular basal cell carcinoma. It's kind of got an infiltrative pattern down here deep. But look what it does here. You go from these very blue cells to very, very pale, clear looking cells. So this is called the clear cell variant of basal cell carcinoma. And it can be very, very pronounced in some cases. So you got lots and lots of pale, very clear looking space in there. And there's a lot of other clear cell tumors in the skin. So it's important to know about clear cell basal so that you can distinguish it from those tumors. And again, I think part of the key, the most useful thing, is to find areas that look like regular basal cell carcinoma merging into these clear cell areas. That really helps solve the problem. And here's a basal cell carcinoma here. You can tell it's in very sun-damaged skin. Got that blue solar elastosis. And around the outside of the basal cell is this pink material, and the pink material is very dense and kind of homogeneous and smudgy and has these little cracks and clefts in it. So this is called amyloid, and we see amyloid in other settings like amyloidosis, but here you can see it along with basal cell carcinoma and some other skin adnexal tumors as well. And it's kind of a breakdown product probably of degenerative keratin and is not worrisome for systemic amyloidosis or anything else. So you can see amyloid deposition sometimes with basal cell carcinoma. A really good example of that real smudgy pink stuff with that little cracking artifact. Here's a basal cell carcinoma that's ulcerated, it's very inflamed. All of this inflammation here is lymphocytes and plasma cells. So that sometimes happens, particularly on the face. You have lots of plasma cells in your inflammatory infiltrate around basals. There's reactive epidermal change there. And so you'd say, okay, basal cell carcinoma, no problem. More basal cell carcinoma here. Oh, but what's this down here? This actually turned out after immunostains to be a nodule of metastatic melanoma. This patient had a known history of melanoma, and so here they had a basal cell, but underneath it was melanoma. So there's a good rule of thumb for everything in pathology, including Dermpath, that just because you find one diagnosis, basal cell in this case, don't stop looking at the slides and ignore the rest, because you can have two diagnoses: a nodule of melanoma, metastatic from somewhere else, underneath the basal cell. So here, the much more important diagnosis, obviously, is the metastatic melanoma. Here's kind of one final case. This is actually like a seborrheic keratosis here. Nice seborrheic keratosis made of bland keratinocytes with horn pseudocysts. But look what's hiding underneath. A little passenger basal cell carcinoma hitching a ride along the bottom of this seborrheic keratosis. So it's always good to look at the whole slide and make sure you don't overlook a little tiny incidental focus of something like this. So that is kind of the basic approach to basal cell carcinoma.